opening soon in Brazil. Look how far we have come. We are now in more than 77 countries, and our goal is to continue developing and evolving within the aesthetic industry to offer even better solutions to all of our partners. We are the main sponsors of the biggest exhibitions around the globe. We have taken part of several chapters of IMCAS, ISAPS, AMWC, just to name a few. I will let our quality certifications speak by themselves. Now, without further ado, let's welcome our first expert of the evening, Dr. Ayman Helmi, plastic. He's a plastic surgeon specialist with extensive experience in reconstructive plastic and microsurgery in Saudi Arabia. Welcome, Doctor. The stage is yours.
Thank you very much. Thank you for the introduction. Hello. Testing, 1, 2, 3. Can you hear me? Am I live? That's the end. Okay. Now it's okay. Assalamu alaikum. Good evening, everyone. Before I start, I'd like to have one simple request from everyone. Can you please turn your mobile phones to silent? Please, all the corners, all the tables, please. It annoys me to have the phone ringing during a conference, so please turn your phones to silent. And if you get any calls, please take your phone and transfer out. Okay. Plastic surgery, dermatology, cosmetic gynecology, and many other specialties are all overlapping together, and we're all hand in hand together. It's a mission for beauty. The beauty for women has a beginning and doesn't have an end. Wherever there's skin, there's need to provide beauty tricks and tips for everyone. I graduated from Canada. Most of my experience over 30 years was in the military hospital, now known as Prince Sultan Military Medical Hospital. Before, I also had a few years of experience at King Faisal Specialist Hospital as well. What do we need to know about the Hyacorp efficacy and results? Hyacorp is not just any filler. As you know, there are so many companies who just buy the brand, the syringes, and they fill up their products by other companies, but this is not the case with Bioscience. Bioscience makes their own hyaluronic acid and they produce their own syringes. The classification of the products depends on the hyaluronic acid and their characteristics. There should be fillers that are different than any other company because their molecular weight and dimensions and resistance are different. I've heard so many comments from so many patients, well, if it's hyaluronic acid, why it should be different? My reply to her, if you have bread, why do you have different kinds of bread? Why the same flour? We can make bread, we can make pasta, we can make many other products. So it's not just a matter of being hyaluronic acid that's the same in every company, and it's not actually the same in every product. We know, we buy, even rice, we buy rice from different brands, they are different, right? But they're priced, but they are different. Hyaluronic acid comes in monophasic, which is the simplest form of hyaluronic acid. Now, different companies, they have their own special techniques of how to make these hyaluronic acids stronger, to get a lift and in firmness, and stronger in how does it dissolve fast or slow, or how much does it absorb water to give hydration. So every form of hyaluronic acid has its own indication to be used, and hence it has its own characteristics how to be manufactured the product. Well, it is biphasic, it means there are some new chemical bonds that bonds the simple form of the hyaluronic acid to make it either resilient as in hard to inject, or viscous as in passes through the needle but it reforms its shape after injection. When we talk the particle size and the molecular weight, these are two different issues. I have a simple example that I just take an example of how to differentiate between the difference between the molecular weight and the particle size. If we have 1 pack of jello, we'll make that jello as a dessert. We can pour only half a liter, it will be high concentration, so that will have high molecular weight. But if we put a whole liter, it will be low molecular weight. Now, after the jello is formed, we can cut it into small, tiny particles or big particles. That's the concept of particle size. And these are the 2 factors that affect how to be injected, whether it with a fine needle or with a cannula, and it also makes a difference what's the effects going to be on the skin. Is it going to be lifting up the skin or hydrating and giving the skin biorevitalization? So the higher the G effect or the G prime effect, it means that elasticity is higher, the firmness is more, it has more lifting capacity, and hence it has better durability, it has better viscosity. Viscosity means that after you inject it through the cannula or the needle, it will form its shape. So it can maintain its shape after the deformation during the injection. So the safety profile, it has been so many years that this has been used with a high safety profile. It's natural, biocompatible, resorbable, biodegradable. Can be injected by minimally invasive procedures. Can be injected as small as a 30 gauge needle or as a cannula 18 gauge needle. It depends which products are you going to use, and it depends also which area and which depth and what is the reason behind your injection. The safety part of it is that it's reversible. It's unlike if you inject fat, you cannot dissolve fat unless you go in with liposuction and take fat if the patient feels that the amount is too big. It's reversible just simply by hyaluronase. It gives an immediate effect, unlike fat. Fat, we have to inject higher volume until the fat percentage settles down, and then we see the final results. And also the variability of fat resorption sometimes gets us in trouble in terms of what remains at the right side compared to what remains in the left side. If it's biphasic, we can see that the long duration up to 12 months and sometimes up to 24 months, but it depends also on how big of a volume we have injected and what's the life pattern of the patient. Those patients, after they have these injections, they should not undergo weight loss because of 2 issues. If patients they come in for augmentation and they start weight loss, they are going to lose their own fat. So the area will be smaller because of the fat resorption, but also this is almost like a sugar, so it's going to be burned out. So if they are going to do any diet, they should do this diet program before the injections. In terms of safety, the safety from PDDE is less than 0.001. The endotoxin less than 0.005, and there have been 0 recalls for this product since it's been in the market. And the reported adverse reactions, 0.01, none of them were lethal or disastrous. The product has a wide range. We have 4 products for the face area and 2 products for the different body areas. We have the fine, the field, the depth, and the volume. So each one has its own characteristics and its own features and indications. We have the fine, which is more of a non-cross-linked hyaluronic acid, specific for biostimulation, like improving the skin quality and hydration and biorevitalization. It comes in a 1 ml syringe. It can be injected with a 30 gauge needle, and this is used very commonly for improving the quality of the skin in the area. The duration up to 1 month. This is the disadvantage, but the advantage of it is that there is no risk of the lumps and bumps because it's non-reticulated. Very commonly used for fine lines, superficial lines, periorbital area, revitalization, and for the neck and décolleté, we call it the transverse lines. Then we go to the lips. The lips is more of a biphasic product. With a biphasic product means that there is some cross-linking of the hyaluronic acid, which means that it's a larger molecule, which means it has a better lifting effect, but also has a longer lasting results because it won't dissolve as fast. So the particle size here is 80 to 150, as you remember when I said about the cutting the jello. So now this is 80 to 150. The difference in the size particles is confrontational. So you have different ones for different effect, different lifting power. It can be easily injected also by 30 gauge needle because the deformational characteristic of this product does not actually destroy the product, but actually reform the shape after it passes through the needle. It has a PDD free less than 1 per million and very low on the toxin level. It is very commonly used for the volume and control of the lip augmentation and is versatilely used, very commonly used. Next one that we can talk about is the face. The difference in the face is actually it's 20 milligram per ml, so it's higher concentration. Although the particle size is the same as the lips, it's still between 80 to 150 micron. That's the particle size. As you remember before, I differentiated between the particle size and the concentration. The concentration here is 20 milligrams per ml. 20 milligrams per ml means it can last longer because it's not going to be as easy to dissolve by the surrounding enzymes. And this is why we use this as the volume part of the face to shape the face using the face product. In this case, it's used for the glabella with its own precautions, the cheek augmentation, the nasolabial fold, the medium, the deep wrinkles on the nasolabial fold, and for the jawline as well. Of course, as we know, that many of the indications that we use is mainly offline, and each one has to take its own precautions and follow the guidelines as the instructions of the science. But this has been of the best products that you can use with great margin of safety. Now, we move to the second part. As far as I know, this is the only Saudi FDA product that has the accreditation or the approval for body filler. As a body filler, Hyacorp Event 1 and F2 are the only two products that are used for body filler, and they are accredited by Saudi FDA. Maybe there are some other ones that I'm not aware of, so when you plan to inject any body filler, just ask the company if you have the approval for Saudi FDA as a body filler or not. We go back to MLF1 as a Hyacorp, which is the softer one. The biphasic product now, again, the concentration is 20 milligrams, similar to the one that we use in the face, but what makes the difference here is the particles size. As if now we're cutting the jello into larger particles, so they have a better capability and they have better lifting effect. And of course, if the particle size are larger, it means that the dissolve process will take longer and longer. So MLF1, larger particles between 200 to 350 microns, and hence we cannot use the 20 gauge needle, because if you try to use 20 gauge needle for MLF1, it means firstly you're going to destroy the particles, secondly you're going to spend long time trying to pass that particles through the 50 gauge needle. So you need a larger needle, and the best thing is the 22 gauge cannula. You just make a small bunch of the needle first, and then you pass that with the cannula. We use MLF1 more of a superficial layer to improve the irregularities subdermal layer or subcutaneous layer. It does give some sort of a volume, but not as much as MLF2, which is the next product we're going to talk about. The MLF1 we commonly use it for the hands for corrections of the concavities and the calves in the body. MLF2 is another biphasic product. It still has 20 milligrams per ml concentration, but the difference here is that it's being chopped into larger particles between 350 to 500 microns, and this is why it has a stronger lifting effect, stronger filling effect, and a longer lasting effect because it takes longer to dissolve a larger particle. This is just common sense. In terms of the safety, it has BBDE free less than 1 per million and low endotoxin levels as the other ones. Commonly used for the buckets for two indications. Now, here, of course, this is what I hate in all presentations, the big tables. I'll try to focus on a few things, just follow the marker, please, in the first one. Now, if we talk about the fine, it is non-cross-linked, it is only 14 milligram, and it is used for biorevitalization, just to improve the skin quality. All these mostly are the same. If you go to the lips, we start to go with higher concentration of 16 milligrams per ml. Now, once we talk about cross-linking, then we talk about particle size, 80 to 150, and it is used mainly for the lips. We forget about the feel now, just feel that the feel is not here. Okay, the face is the one step more than the lips. It is 20 milligrams per ml. The particle size now went up to be 80 to 150. And it's used for different parts of the body, of the face. Once we go to the MLF 1 or 2, we're talking about the body fillers. MLF 1, still 20 milligrams per ml, but the difference is the particle size is 20 to 350. MLF 2, which is the biggest gun for body fillers, concentration is still 20 milligrams per ml, but the particle size is 300 to 500. All of them have the same low endotoxin level and the same BDDE less than 1 per million. Believe it or not, it's one of the fastest growing cosmetic procedure on the globe, which is the buttock augmentation, maybe body fillers, but buttock augmentation has gained a lot of popularity. Now, why are these happening? Mainly because of the media. As you know, there are certain celebrities that their brand name has been followed by larger buttocks, but I think the other reason is, in the past, buttock augmentation was only in the armamentarium of plastic surgeons, either buttock implant or fat liposuction and fat injection. This used to be the past. If any patient wants to have buttock augmentation, she must undergo surgery. But nowadays, this is being done commonly by injections only. So not only plastic surgeons are doing it, but many other specialties. And of course, the cost is less than before. There is one more advantage. If a patient wants to have a big buttock augmentation, she has to negotiate the size that's going to be done during surgery. And if that size doesn't suit her, too big, can be taken out. If it's too small, she has to go to replace it. But the advantage of these injections is that she can have this in steps, she can have it in serial injections. It's an outpatient procedure. It's according also to her budget. At the beginning of the year, she has some budget, she can have 10 injections. At the end of the year, she can have more budget, she can have more injections. These are examples, and most of you have seen it very well. The Hyacorp, the fine line for the lips, and for the angle of the mandible. If you want to know, this is the angle of the mandible here has been built. This one is very vague. There's no definition of the angle of the mandible. This has been defined very well. And the dorsum of the hands, very nicely done, without any surgical procedure counted. And buttock augmentations. There's two things that you can do for the buttock augmentation, either the size as a whole, or mainly the lateral lips, for here, for example, because this looks more of a muscular body. This is feminine. This looks more of a muscular body. This is feminine. This straight appearance is usually correlates with a muscular body, but this is more feminine. And the advantage is that you can actually have injection quite frequently. Thank you very much.
Now I would like to invite an internationally recognized professional with over 10 years of experience in the aesthetic medicine field.
Thank you very much.
Dr. Christopher is an Italian plastic surgeon, an active member of the Italian Plastic Surgery Association, and a Hyacorp Event. The stage is yours.
Thank you very much. Thank you very much and welcome to this event. So let's start with checking which are the options for a volume replacement. As the doctors say, we can go for implants, we can go for fat transfer. As a plastic surgeon, I always tell the patient, if you are a good candidate, you should check always the fat transfer first, and then going for the dermal filler. But dermal filler, yes, it's true, they are growing in the years, and this is a procedure that we get request every single day for. So when we talk about implants, of course, it's something that cannot be permanent and something that, unfortunately, according to the international scientific company in general, they are regretted by the patient by 60% after the implant replacement. Fat grafting stays, in my opinion, one of the best procedures to increase and replace the volume, but nowadays we check or we do everything with the body filler. I believe we can skip the permanent filler because we don't use them anymore. I spent 2 words about the semi-permanent filler because in the reality these are not fillers, these are collagen stimulators. So an association between the two can be impossible with the non-permanent, with the hyaluronic acid and the others. But still, they don't give volume, they give result in long term in terms of traction, in terms of lifting, because they produce new collagen. Most of the time they type 3, which is the fibrotic one. The hyaluronic acid is the same substance that we use, that Hyacorp use, that Bioscience produce, and it's safe. The particles are big enough to give enough volume, and to maintain the result, don't get me wrong, I don't want to say 2 years, because this is not true. Up to 1 year and a half. It's true that after 2 years, if we do a biopsy of the site of the injection, we can find still hyaluronic acid. But of course, the volume, the cosmetic result is going to be less. It's normal. There is an economical absorption within the time. Which are the benefits of the hyaluronic acid? First of all, it's a safe substance, so we have in our own body. It's a fast healing. The patient has an immediate recovery. 3-4 days of swelling and pure redness, these are normal. Imagine when you do the lips, you put 1 ml, the patient has the swelling for 2 days. When you inject 50 ml with Hyacorp area, it's a proportion. You don't need anesthesia, you don't need sedation. So all those patients that are not willing to go under general anesthesia for a surgical procedure, they are good candidates. They can be good candidates for the vacuumization of the body, of the filler in general with hyaluronic acid. It's a procedure that we can repeat. Dr. Hyman says something super true. We can build the volume step by step, and this is the safest way to do it. We don't need to inject 60 syringes in one session. Keep in mind that we are creating an inflammation. More inflammation we create, more absorption of the filler we have. It's a dog-biting state. So the step injection, the several session injection is the best option to give the result to the patient, a long, stable result. And let's talk also about the money problem. Also for the patient, they're going to spend something every month instead of giving basically a loan for one single procedure. It's a better option. And trust me, the result stays stable much more than normal. And it is reversible. Every time I do a training, the doctor, they ask me, but is it working with the hyaluronic acid? Well, we need a simple trial. We just took a ball, we put the filler inside, we just put the hyaluronic acid there, and you can see the filler melting. So yes, it is reversible. The hyaluronic acid works and it destroys the filler. It doesn't mean we have to use it, but sometimes we can have some complication even after a few months, and most of the time it's because the patient is not a diligent patient. And in this case, the hyaluronic acid helps reducing what is the problem, what is the inflammation. So they are different, the body filler in terms of amount, in terms of concentration, in terms of the size of the particles, as we just said. They last longer. They are best to be injected. I don't want to say deep dermis because we don't have deep dermis, I say subcutaneous tissue, so fat tissue, superficial fat tissue and deep fat tissue, okay? And of course we are talking about the plastic fillers. But what is the thing that makes bioscience one of the best companies, not because I work for them, but because I tried the others as well? Hyacorp has a thixotropic effect. It's very elastic. You inject the filler, it might be a bit hard while you do the injection if you are not used to, but the good thing is that the patient, they don't feel the filler 3 days after the injection. And the first question they ask you is, can I already sit? Yes, you can 100%, of course. Long sitting patient who works in the office, the day after they have to stay sit for 8 hours, I suggest always to change position time by time. But the filler keeps the shape, the filler adopts itself with the skin. And if you do the injection and you see the hardness after the injection, I bet you, after 10 days, after a week, you don't feel the filler anymore and you have the volume more. This makes the filler more stable, it lasts longer and easier to inject. So, injection technique, in terms of MLF2 for the Botox indication, I said it might be the best option, but it is not always the right option. We have patients where we cannot do the butt filler, because when we have massive weight loss, when we have patients with saggy buttocks area, when we have patients with skin deformity due to fibrotic tissue, the filler is not enough to solve. We can use the filler, but we have to combine procedure, and most of the time the first procedure you have to do is a surgical procedure. Could be a perfect indication. According to my taste, I wouldn't treat a patient like this because she has already a perfect shape. I cannot treat a patient with a very saggy buttocks. Because the problem is the patient thinks, okay, you put the filler on the lower third of the buttocks, we lift it up. No, we are adding weight. We have a high particle size and the molecular weight is high as well. So if I add weight in something which is empty, it goes more down, okay? So the patient selection is the first step in order to be safe with the procedure. Quick talk about the anatomy, not because I have to teach you, because I'm sure 100% you know, but most of the time the patient and the doctors also, the training, they ask, but what is the chance I give embolies? What is the chance I inject into the artery or into the vein? Well, first of all, if you're injecting with a cannula and you are not stopping the patient, there is no chance to go intravenous, intravascular in general. Then, we have 3 major muscles, gluteus maximus, gluteus and minimus. The minimus is very deep. Oh, sorry. The minimus is very deep. The medius and the maximus are the muscles we are dealing with. Why we are dealing with? Because if you see, the medius is exactly on the top of the maximus. And this line is a transition area where we will struggle to inject the filler because there is kind of a fibrotic septum. It's a retaining ligament, like the one we have on the face, like the one we have on the tummy. But these are the place of the injection because when you inject the filler below or above this ligament, the filler is safe. And remember, we are always on the top of the fascia. We don't even touch the muscle. And all the nerves that are in the artery, they are below, they are very deep, so there is no chance that we can inject inside this artery. We can find some perforators, but still, if we are not stopping, if we are being gentle, if we are finding our way, if we are in the right place, there is no chance to give this kind of a complication. Skin. Super easy. I made a scientific work with ISAPS about that. I did a presentation last week in Dubai in the World Conference. Now, we have 2 layers, epidermis, dermis, and hypodermis, and this all of us we know. But talking about the healthy skin, be honest, and please raise your hand. How many of you have a patient with a super healthy skin, no stretch marks, no irregularity, perfect? I never had this kind of patient. Most of my patients, they have this problem. I define here unhealthy. I would say cellulitis, I would say water retention, I would say patient with 3 kids, it's normal, guys. I'm talking also about men, because we treat both men and women.
told, and as you can see, she's coming to us to improve the shape and the volume of her buttocks area. Now, the first thing we have to do when we have such a patient is a proper examination of the anatomy. As you can see, we don't have to stop only on the buttocks area, but you have to check also the shoulders, the back. Can you just relax your arm? So, when the patient is relaxed, we can see there is a slight difference between the height of the two shoulders. It's normal, all of us, we have kind of scoliosis. So, seeing that, automatically we can see that there is an asymmetry also on the two different sides of the buttocks. In this case, we need to feel the hip dips area, so we do a hip dips correction, and at the same time, considering that she has a good skin texture, when we will add the filler to give some volume, we will have a slight improvement and lifting of the buttocks itself. So, we are going to work on the lateral area of the buttocks to correct the hip dips, and we will work on the upper third of the buttocks in order to correct this C deformity where most probably the fat just slide down due to the aging process. So now we're going to have a closer look to the patient's anatomy in order to mark the area where she needs the filler. First of all, let's see also the skin quality. Can you please squeeze your muscles? We will see that when she's contracting the muscle, there are few irregularities on the skin. Relax, thank you. This will be improved a lot after the injection of the filler because the hyaluronic acid repels water and improve the skin quality itself. So let's mark the area. Let's see which are the limits of the buttocks. So from the lower part, can you squeeze it please? We see this crease here on the lower buttocks area, which is marking the lower edge of the buttock. I touch the bone, the spine, and I mark a nice curve here going till the iliac crest. This is the buttocks area that we have to treat. We have the muscle here, the gluteus major, and here the gluteus medius, and the gluteus minimus is behind this muscle on the back side. So, we can divide basically the buttocks in three main areas, which are the upper third, 1, the middle third, 2, and the lower third, 3. Whenever we have a bit of laxity, we should avoid to inject the lower third, because when we inject the filler, we are adding weight, so automatically we are pulling this one down and giving a longer look, a longer shape to the buttocks. In this case today, I checked the patient also from the front view. This is the area that we have to correct. We don't inject where is the volume, we inject where is the lack of volume. And if you follow the line from the back side, you will see that the shape, when we correct the hip dips, it's almost similar to a beam. And we mark the middle line because when we do the injection, these are our focus area where we inject. Personally, I like to use as an entry point the culotte de cheval, so the lower third of the buttocks. Why? Because here we have a nice representation of the fat tissue, so it's going to be very, very easy to find the right plane and do the proper injection. Keep in mind that not always one session is going to be enough to fill completely this area. Why? Because if here I can pinch a nice area, a nice quantity of skin, same here, so if I have to give volume, I have plenty of area to inject. When I have to do the hip dips correction and I try to pinch the trochanteric region, I see that there is not much pinching. Why? Because here in this area, the fat tissue is less represented compared to the rest of the buttocks. In this case, I'm going to use this entry point in order to use a cannula, which allows me to inject here, 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 and here. This is a patient that she might need around 10 syringes in total, 5 each side. Don't forget that the maximum amount of syringes which the company recommended for the injection is 14 in total. So 7 each side, or anyway 14 in the total to balance and to fill the gap that she has. So we finished the drawings on this area. Of course, the best solution is when we start the syringe. If I'm planning now to inject fine syringe in this part, usually I inject 2 or 3 syringes, then I ask the patient to step up and stand up again. And I do again the drawings to check if there is more, if she needs more filler in one side, in one area instead of the other. Now we did the right side and we can go to the left side. I don't have to remark the 3 areas because I know already, and you can see now the perfect shape of that being I was talking before, which is following exactly the lack of tissue and the depression that she has. We mark a middle line of the depression, because when we do the injection, we have to pay attention that we don't inject too much close to the edge. Why? Because if I inject closer to the upper edge, I get this. So the depression is showing more. If I inject too much closer to the lower edge, I get this. So the depression is showing more. The goal is with the first syringe to create a scaffold in order to lift the skin, and then we go, of course, in this case, on the deep fat layer, and then we inject small bolus, so anyway we will see a feeling under our fingers, our hands. We inject small bolus in order to lift the skin. Again, because she has a tight skin and quite firm, she might need 2 sessions in order to reach the perfect result. So guys, we are going to talk now about the 2 different products for the body filler. We have the MLF2 and the MLF1. Both are amazing hyaluronic acid products. Both contain 1 syringe of 10 ml each. The main difference is, of course, on the molecular weight, on the size of the particles. The MLF1 is used usually for the callus correction, for the intimate area, or for the correction of the small cavities, and also for the hands rejuvenation, which makes this filler a bit more soft, a bit more smaller in terms of particle. We are talking about 200 to 250, 300 microdalton. When we talk about the MLF2 is the thicker filler used to give volume to the buttocks area. It can be injected on both deep fat layer and superficial fat layer, and the weight, the size particle is from between 300 and 450 microdalton. Now, both fillers are amazing and both can be combined. I often use, when I do buttocks in augmentation, the MLF2 on the deep fat layer and the MLF1 on the superficial fat layer. Why? Because in this way, I'm not only giving volume and establish the loss of volume that the patient has, but when I put a bit more superficial, the MLF1, being hyaluronic acid, the hyaluronic acid recalls water, which gives moisturized effect to the skin. So I really improve in the long term the skin texture and the skin quality. The MLF2 has to be injected with an 18 gauge cannula and 10 centimeter long, because allow us to treat the whole area of the buttocks. Now, this cannula, whenever we talk about callus, can be used also with the MLF1. It's quite easy to inject and you don't need much strength. But when we talk about hands or small correction, we are going to use a 21 or 23 gauge cannula, which can be 7 centimeter or 5 centimeter. For the hands, usually 21 gauge, 7 centimeter is enough, because from 1 entry point we can treat the whole hands. So now the patient is laying down on the treatment bed. I like always to make her laying down on her tummy and put a small towel under the area that I want to treat, in order to have all the full view of the area, and also, sorry if I do that, to relax the area. So in this way, for me, it will be much easier to find the right thing. Now, I want to spend a few words about the importance of being in a sterile or as much sterile possible environment. Because one of the first complications that can happen whenever you do any kind of filler is the infection. But if we avoid that since the beginning, we can be sure that we don't have this kind of problem. So it's very important to isolate the area with a sterile drape after the disinfection. As a disinfectant, I like to use the Corexin because it's not staining the skin, and it's a surgical disinfectant. And after that, we can start the injection of the local anesthesia and start the procedure of the filler injection. Okay, we're ready to infiltrate the local anesthesia. I'm starting the injection of local anesthesia, okay? So I do local anesthesia on the entry point only. I use usually 0.3, 0.4 in total of lidocaine, plain lidocaine with a 30 gauge needle. We always inform the patient I'm doing the local anesthesia, okay? So now, because there is the black, I will do the injection just a bit further than the cross we did. So 1, 2, 3, 6, okay. And the goal of this anesthesia is to create, and I don't know if you can focus and you can see, a superficial bubble. Can you see? Now, why this is important? Because in this way I'm doing already an hydro dissection. So when I'm going to do now the entry point with my needle, I'm sure I'm in the right plane. And I will show you the difference of the planes when we use the cannula. Entry point. This is my personal technique. I go exactly perpendicular on the area where I did the injection of anesthesia, and I just push. I push till I feel a small click under my fingers. That click means that I went through the dermis. There is no blood. I always check if there are superficial veins. I remove it. In total, I would say it went in around 3-4 millimeters. So once we take our syringe out of the box, in this case MLF2 from Hyacorp MLF2 from Bioscience, we just slip it off the aluminum foil, and we find in a sterile environment our syringe containing 10 ml of hyaluronic acid. I give this one to my beautiful assistant, thank you very much. I take my 18 gauge cannula 10 centimeter long. We remove the lid of the syringe. We just screw in the cannula, removing the lid, and we always prime the cannula. Now, these cannulas are quite good because you can see here, please zoom in, there is an arrow at the base of the cannula, which is indicating exactly the exit point, the way how the filler is coming out, which way the filler is coming out. And this cannula has 10 tags which are indicating the centimeter of the cannula. So each tag is 1 centimeter, and when we reach 5 centimeters, we have 2 tags. So we know exactly where we are with our cannula. Now we did the entry point, there is no major bleeding, it's normal to find a few drops of blood, we clean the cannula, this is a sterile cause with the disinfectant, and we go perpendicular. Now, if we want to go on the superficial fat tissue, this is the right layer. We can see that pushing down with the cannula, the skin is pulled down itself, means we are pushing on the superficial fascia, which is pulling the skin down more than the fibrotic septum. If, like in this case, I want to inject in a deeper layer, so in the deep adipose tissue, I pinch the area, I do a slight pressure with my cannula without forcing. Tell me if you feel any pain. I went through the superficial fascia, now I'm deep. And you see that when I bounce my cannula, there is no tissue recalling, no skin recalling, so it's flat. Do you feel anything? Just some annoying movement, maybe, but not pain. Okay. Doing that, I will tilt slightly my cannula. I like to do a slight massage in the area and going to the deep fat area. Tell me if you feel pain. Why I ask the patient to tell me if she feels pain? Because the patient feels pain if I'm superficial and I'm touching the dermis, if I'm touching the muscles, or if there is a lot of fibrotic tissue and I'm breaking these fibers. I start from the lateral part, from the medial parts, okay. If I feel some obstacle, it's enough to just tilt the cannula or keep doing a constant pressure and do the massage here. I mean, I'm not superficial because I'm not pulling down the skin. The cannula is freely moving inside the fat tissue, and I can start my injection. Are you ready? I always pinch the area I have to inject, and I start with the first retrograde injection, going back and forth in order to create the scaffold which will give the support to the filler, to the other filler. As you can see, I'm not traumatizing the patient, I'm not stabbing the patient, and this is very important. She is relaxed. Are you? Sometimes she feels some pain. This is normal because we go through fibrotic septum. Just tell me, no words, okay? And we finish the first stage. Okay. Can I have the second one? Thank you. We keep doing the injection. When I inject, I feel the filler under my hand, under my finger. So I'm sure I'm injecting this in the correct area. Okay, can I have another course in the third syringe? We do some massage here. So I'm planning to inject 5 syringes each side, maybe 4. So after the third syringe, I will ask the patient to stand up and I can do the evaluation and in case correct my drawing. Okay, we just did 3 syringes, okay, and I always like, and it's important for you as well, to ask the patient to stand up in order to see if there is a major difference or if there is any area that should be filled more than the other one. So after 3 syringes, this is the result, and I believe you can see there is already a huge difference. I inject in the right plane, I focalize my injection in the front area, so from the side and from the front, you see much less depression. Now the goal for me is to inject this area in order, sorry if I do that, to push this one out a bit. I don't want to go too much further on the front area because here we start entering the growing area where you have the lymph node. So we don't want to inject also the lymph node, so we stick with this part. This is a natural, normal depression that the patient has because there is the bone of the rear crease, the upper trochanteric region. But she doesn't have the gap that she had before, so the hip tips are already almost completely covered. Keep goes with the surgical disinfectant on the entry point. I like to do a massage, which sometimes the patient doesn't like too much. Okay? I check from the front, there is no bumping anymore. I check from the back side, sorry, squeeze your muscles. Perfect, relax. Relax, relax, another small massage here, and I see that my depression is still a bit in this area, okay, and show me the front, yes, front, and a bit in this area, show the camera. So now I will inject here and here. Very honestly, I think that 1 syringe can be enough, but the patient will ask for more. So we stick to our plan 5+5 in order to give also a below upper volume. I want to say once more, no. This kind of injection would be the best to be done while the patient is in a standing position. I don't recommend to have a patient to do the injection in a standing position when you are starting using the product. It's a more advanced procedure, but of course it gives you the best three-dimensional view of the area that you are injecting. Okay? So let's go back to the bed and we finish. So I did the 4th syringe, I did while she was standing up, I have to be honest. I believe you can already see the huge difference between the 2 sides. Now, to me, the hip tips is corrected here. What I want to do, because she is an amazing patient that she deserves, is to use the MLF1 all over this area in order to give still a bit of volume and to improve the skin texture. We can choose to do while she's standing up, or we can do while she's laying down. It's the same, okay? Our MLF1, same cannula of 10 centimeter and 18 gauge. I go always from the same entry point. I clean always the area. Slight massage. When she is in a standing position, it's a bit more tricky because there is the weight of the tissues on the cannula. So now I am on the superficial fat tissue, and very, very quickly, nicely, I inject a bit of filler with the retrograde technique. Tell me if you feel anything, please. Try to resist, you're doing very well. I'm releasing a bit of fibrotic tissue and I can feel under my cannula. Remember, we are using a cannula, so if we have to change the direction, we have to go almost completely out. And that's it, done. So we finish our injection, we clean completely the area, we put a nice plaster here. Look the difference, patient is happy, front, good. She's a strong patient, she's perfect. Stay like this. So I prefer to remove the black mark because it's staining the skin, and I go with the normal white pencil, the one we use usually also on the face. I just did the same marking. I will mark again my entry point from here. So from this point, I will reach all the area I have to fill, always avoiding to go too close to the upper and the lower edge. Are you ready? You can lay down, please. So here we are again on the right side. I will start always disinfecting with my lovely chlorhexidine. Again, make sure, sorry if I do that, make sure that the thigh is relaxed, there is no contraction of the muscle. And I do my local anesthesia. This is the same syringe I used before. 0.2 was the injection. I'm doing the injection of the anesthesia, okay? 1, 2, 3, zick. Always suction test to be sure we didn't take any vein, and injection very slowly because it burns a bit. We create our nice superficial bubble. You can see here. Okay. Thank you very much. And we go with our needle perpendicular to create the entry point. 1, 2, 3. She has a strong skin. It's done. Okay. We can start the injection. So in principle, we go on the deep fat layer. So from here, I use the left hand here. A good surgeon should know how to use both hands. Credit to me. Okay, pain. We are here, 10 centimeters. I start doing my injection, always retrograde, because we want to create the first scaffold. Are you okay? Tell me if you feel anything. Change our direction, we will go more on the hips area. It's normal sometimes to find some fibrotic septum which makes your life miserable. There we go. When we fight with fibrotic septum, automatically there will be a bit of blood coming out. It's normal. And now we start focusing on the middle of the depression. I touch where I injected the filler. I go a bit more lateral. Stretching the skin can help you to stay on the same plane, in the same layer. Okay, did you feel any pain? Me neither. Just a bit, because I went a bit superficial. It's fine. Okay, the second is done as well. Always clean the area. This is the third one, because my plan is always to stay in between the 4 or the 5 syringes. I'm doing a small massage and I ask the patient to stand up again. This syringe here, as I said before, there is an asymmetry between the two sides. This part goes deeper and I can see that the patient needs a bit more in this area. So we are getting closer to our entry point. Again, we don't feel this groove here because it's part of the bone area. We don't touch it. I check the patient also from the side. Here I stay a bit more posterior. I don't go too much in the front, and I check from the front as well. And yes, I see that the depression is in this part. Okay, so this will be my main injection. Okay, fourth syringe. We did again the drawings while she was standing up. I go always on the deep fat layer, and this time, because I have a single hair to lift, I pinch the skin, I reach my point, I press with my finger, I feel the filler coming out, I re-pinch the skin and then inject a small bolus, like 3-4 ml. The bolus should be massaged after that in order to avoid any granuloma or any complication like biofilm formation. We asked the patient to stand up again. So we did the fourth syringe while she was laying down. As you can see, the back side now is filled completely. She needs still a bit on the front part. And like we did for the other side, we're going to use the MLF1. Yes, thank you, give me the pen. We're going to use the MLF1, focusing a bit in this part in order to fill and give the volume here, and then on the whole area in order to give an improvement of the skin. I do the last syringe if the patient allows me while she's standing up. Can you do that? Okay? 1, 2, 3. When you inject in the standing position, try to be as much fast as possible so the patient doesn't feel anything. I'm seeing exactly how this part is filled now. It's already almost gone. Okay, done. Now I fade the filler all over the area. Are you okay? A bit more just forward here. And then we go, to improve the area of the skin here. Good. So we said she has an asymmetry, so we need a bit more on one side. We are still below the 14 syringes. This one is the 11th. We do some bolus on the middle of the trochanteric region. I marked the area before. The patient, she's a very good patient. I pinched my area. Remember when I said do not struggle, it's an area that might need pulsation. I can feel already that the skin doesn't have more elasticity. So for me, this one, anyway, is the result, is my last syringe, because I see that there is no more room. She can come back after 3 weeks. We see how the result it is. The filler in the meantime grows by 10% because being hyaluronic acid is recalling water. I do a massage of the area, which is a bit annoying, I know. I'm trying to be gentle. I clean my marking. I check the front of the patient. I believe it's fine. I want to focus on something. If you see the patient turning slowly, you still see this small depression here. Now, Can you please squeeze your muscles? This area is an area, relax, thank you, where is a retaining ligament creating this dimple. Moreover, we did the injection from
3+3 syringes to each side. I never overcorrect because this small almonds, it comes completely around 3 weeks after. 5+5, patient of mine, she did surgeries with me, she did tummy tuck, tight lifting, not a very good skin quality, but she insisted to fill the gap, so okay, let's try it. Start with 2, 3, 4, 5 syringes until we got a nice result. And she is the same one, I'll show later, I did the projection for the buttocks. 3+3 for the dip correction, 4+4. You see, this picture is taken 3 weeks after. And I can tell you it was exactly the same of the first one I showed before. And there was still a small gap, which was completely filled, because I feel that improved the shape again. 6+6. I never sell the procedure as a butt lifting. Never. Because I believe that there is some strength that we cannot buy, that we cannot destroy, which is the gravity. So if I'm not in weight, how can I lift something? But still, if I have, like in this case, or in this case, a firm skin, a firm buttocks with the injection in the right area, you get some lifting. Now, in terms of projection, this is a patient, the same as I said before, 8 syringes for the projection. She had a laxity of skin, not a good candidate, I know, but I'm showing you because I want to show you this step. It looks long and not nice. This is immediately after. 3 weeks after, this one becomes completely round. Because whenever you want to create the projection, you want to improve the projection, this is the area to inject, the upper third. If you inject in the middle, you have more chance for the buttocks to go down. So you have this long line on the upper part and not in the lower part. So trust me, this is the way to do the filler. And if the patient, if you can inject even 20 syringes, of course you can fill immediately the gap and you immediately round as she wants. 6+6. I said before, 9 as well. This is a male patient. Perfect roundness is not possible because we shouldn't shouldn't eliminate the C deformity that the male had, that we have, because our muscles are way bigger than the female muscles and they are slightly anatomically different. So this depression here needs to be kept. 7+7, volume, lateral projection, and lifting. And let's talk about MLF1 whenever we do the cows. I hope there are no videos here. No, good. Cows indication, whenever we don't have the adult muscle or congenital small cow, or no responsive to target exercise. Anatomy. Be careful. I know that sometimes 1 entry point is better, but in the middle we have the pupillar artery. Aorta, iliac, femoralis, popliteal. It's an artery around 1.5 centimeters. If we pinch with the needle, I don't know, you wouldn't stay with the fingers there. So the best way to inject, because we have to inject the 2 main shafts, is 1 entry point for the medial shaft and the lateral entry point for the lateral shaft. Be careful when you go the lateral entry point, because there is a branch of the sciatic nerve which is getting superficial. So do not traumatize the area too much, otherwise the patient can have the sciatica-like pain. Some before and after, asymmetry of the 2 cows. This is the front view, 2 syringes on the right cow for 1 syringe on the left one. And from the back view you can see it better. Super simple and very quick procedure. Same cannula, MLF1 is the filler you should use. A nice massage. It's very easy to find the pain because you just go on the fascia and then it's sliding very easily underneath. Just avoid this, I will see when you look at when you look at the cow injection. 3+3, straight leg. 3 syringes each side, in total 1.5 per side, and you can see a nice and natural curve. Try to maintain the anatomical proportion. The cows cannot be bigger than the thighs. I cannot inject too much here because if you see, it's already almost the same on the knee area. When we don't do the calves, whenever we have a vascular disease, Whenever we have varicose vein, whenever the patient has some problem like this, we don't do an injection. Diabetes. When we have patients with diabetes, we should avoid to inject a big amount of volume on the legs because we risk problem, we risk complication. I don't want to even think about the compartmental syndrome because we shouldn't reach this level, but still, if the patient has an infection, if the patient has a not controlled diabetes, and so there is a problem after the injection, there is going to be a real problem to heal from that infection. Just like previous treatment with permanent filler, the same. Be careful if the patient had implants before. The calf implants should be placed under the muscle, okay? So even if the patient has a small calf implants, you can do the injection, but if the implant is placed on the top, do not go with the filler, okay? Hands, MLF1 always, elderly hands, poor skin quality, loose skin. It's written with pigmentation. Of course, the filler will not remove the pigmentation. Visible vein and tendons of the dorsum and absence of subcutaneous tissue. Entry point, you cancel the mark. Okay, entry point, basically, they are 1 here and 1 here. You can check yourself if you bend, you do a supination of your hand, you feel 2 small grooves close to the bones, and these are the entry points. 1 entry point usually is enough to treat the whole. And contraindication, any skin condition like psoriasis, hyperkeratosis, precancerous lesion, arthritis, and Raynaud syndrome, we don't treat the patient. I had personally a bad experience during the training in Abu Dhabi. Patient, she was 2021. The patient did the COVID vaccine, and she came to, I was doing a training, and she had some keratosis on the palm. And they said, what is this? Oh, no, nothing, it's like stress, sometimes it happened to me, but you can do it, no problem, no problem. Okay, I was a training aid. There was complication, there was swelling, infection of the area, probably it was something caused by the vaccine. So whenever you have any skin condition on the hand, do not treat the patient. One more thing, ask if the patient, they have cats or dogs, if they have pets, because they don't have to touch them at all for the next 24 hours after the injection. It could be even 2 hours, but I would prefer to say 24 hours, because there are bacteria which can cause infection. And I saw patients with huge complications, huge swelling, a big infection of the hands after filler, any filler, not either, any filler. And they said, yes, but it's normal for me. They came to the clinic with the dog and the cat, and they were petting the dog immediately after, and this can cause problems. Previous treatment with permanent filler, we don't treat any. Off-label indication. Now, it can be used for the intimate area, for male and female. I always say, and here we have an expert, that everyone has his own specialty. So if I have to do a penis enlargement, I refer to the urologist. If I have to do a lab rejuvenation, okay, if there's a patient of mine, I can even do that, but usually I refer to my colleague gynecologist because they know better than I do. Anyway, off-label indications. So the company, they don't suggest to do this procedure, but we can still use it. Small amount, MLF1 can give a good result. Personally, I never use the filler for the breast because this is a common question. Sometimes, on my patient who had did surgeries before, if there is a bilirubin, because maybe they lost weight, or because they got pregnancies after the breastfeeding, then you can still feel a bit of lack of volume on the upper pole, I might go with the MLF1, curved cannula, but always under the skin, never under the gland. Okay? Complication. We can have immediate and late complication. They are exactly the same of the normal filler. Immediate reaction, reddening, sensitive skin, swelling, contrairregularity, skinval effect, hematoma, hypersensitivity. Ischemic complication. It's very difficult to get ischemic complication when we go for the buttocks augmentation. Usually they don't see. I saw few with other kind of filler, and they came to me to treat the surgical problem. Delayed side effect: bacterial infection, biofilm formation, nodules, granulomas, migration, necrosis. Of course, they might be related with the immediate reaction. Now, I saw some complication, not only with biopsy with Hyacorp, also with other fillers. Patient that after 3-4 months they come to you with lump redness. Most of the time this is happening because they had some trauma. In the video you saw, I said to the patient, no slapping, no squeezing. I know it's awkward, but you have to inform the patient that also in the private moment they should avoid to traumatize this area. Ask the patient if they did a huge exercise after the injection, because this can cause this problem. Rarely you can have the biofilm. The biofilm is a protection of the bacteria that doesn't allow the antibiotics to destroy them. And it can happen whenever you have an implant. So how can happen with the filler? When you have a granuloma, when you have a lump. And how you can create a lump with the filler? Because you inject too much. Only for this reason. You inject bolus in a big amount, with a big amount of filler, which can cause the granuloma, which can cause the reaction of the capsule, and if there is an infection, the biofilm formation. What we do during and after, of course, we saw in the video, we'll be fast, disinfect the skin. I did it, as I said, the filler, the first surgery where we done 1 ml of the token, inject local anesthesia on the entry point. The hydrodissection is something super easy. Really, it helps you to go straight under the dermis and to be on the superficial fascia with the cannula. 18 gauge cannula and needle, inject the filler also where the patient is standing up. Do not overcorrect, plaster on the entry point, compressing garment. The swelling is normal for 4-5 days. After the injection of big amount of filler, I prescribe the azithromycin. Massage the area, ice packs, avoid gym and effort for 12-15 days and follow up after 3 weeks. Now, stupid things, because we have always to take care of our patient. Inform the patient about the ice pack, to apply the ice with the fabric in between. Why? Because sometimes that it happens, the patient feel the redness, feel the heat of the skin, they put the ice their way, and after 20 minutes of the ice they have burn. So inform the patient about the fabric. Thank you very much, and I leave the stage to our beautiful Patricia. Thank you.
Thank you, Doctor. I would like to welcome our next expert to the stage, Dr. Hiba Sarhan. Dr. Hiba Sarhan is an obstetrics gynecologist consultant. She is the head of the Quality Affairs Medical Team and the Women Healthcare Clinic, WHC, at the Suleiman Al Habib Olaya branch in Riyadh. The stage is on.
Good evening, all. I'm Dr. Sarhan, gynecologist. Actually, as Dr. Camilo said, it's of label indication to use this filler in genital area. But what about the products in Hyacorp can be used in the genital area? We have two products from Hyacorp can be used in genital area as a label indication. The first one is Hyacorp Fine, which have a particle size of 80 to 150 units. And the other one is MLF1, which have 200 to 350 units. Both of them have their indications. Regarding MLF1, can be as a body contouring or a labial augmentation by filler. Regarding Hyacorp Fine, for other procedure or G-spot amplification or for C-left to enhance sexual like G-spot or Osho. This is Hyacorp Fine, which contains 14 milligram per ml of Hyacorp and 80 particular size of 80 units. MLF1. What are contraindications for labia majora filler? Short pregnancy and breastfeeding, as no studies about safety of both pregnancy on the filler or filler on pregnancy. Any autoimmune disease which can cause late complication like granuloma or lump. Any skin inflammation or even vaginitis, any vaginal infection filler should be avoided to avoid the biofilm or the infection. Any presence of permanent filler, and as Dr. Colonel said, no more permanent filler available right now. Any allergy or history of allergy to hyaluronic acid. Any chemical peeling done, the patient did any chemical peeling during the last 2 weeks. What is the possible complication and how to avoid it? Immediate side effects are minor and mostly can be disappear on their own, like hematoma, bruising, pain, swelling, redness, itching, and all of these complications or side effects can be explained to patient during signing the consent, and how to deal with it can be also explained to patient during her consent. The early complication which can happen within 1 to 2 weeks post-intervention also is avoidable, like infection or hardness, abscess, and necrotizing fasciitis, which also is rare and can be avoided by right patient selection to avoid the patients with history of any sign of infection, and to disinfect and sterile the area well before starting the procedure. Mid-term complication can happen after 2 weeks, like wrong placement or displacement or non-uniform distribution, and this can cause patient dissatisfaction or unhappy patients, and this can be considered as a complication also. Long-term complications like seroma or granuloma or autoimmune response reaction, and low aggressive infection or biofilm by the weak bacteria. What we will tell the patient during signing the consent, and the consent is very important, as Dr. Carmel said, it's off-label indication. So we should explain to the patient that this is an off-label indication for this material, so she should face some side effects and how to deal with it. First, she should stop aspirin if possible 10 days or 7 days before the procedure to avoid the hematomas. No chemical peeling. The consent should inform the patient about the infection, hematoma, bruising, late complication, any side effects she should face. She should have a number to contact before she will face it or deal with it alone. After procedure, she should have a disinfectant or a cream to disinfect the entry point, because it's the same as the putty filler. We have the same technique. We will have an entry point. We will use the 7 or 10 cannula, 80 gauge, 18 gauge. She should have no compression for the area for 3 weeks, no sexual intercourse for 2 weeks, and she should not traumatize the area for at least 2 weeks. She should drink plenty of water, this is the common advice for any filler, to take zinc and vitamin C, and to drink plenty of water to have longer duration for the filler in her body, and to hydrate the area, as hyaluronic acid also is also a hydration factor for the area. And she should contact the doctor in case she faces any side effect which is not mentioned in her consent. What regarding the non-cross hyaluronic acid indications in genital area, also it's off-label indication. Rejuvenation and hydration of vulvar area, and Hyacorp procedure and C-left procedure. Hyacorp procedure first described by Matlock 2001. It enhanced the sexual stimulation to the G-spot. When we inject the hyaluronic acid, which is non-cross-linked, in the G-spot, it will amplify the area of the G-spot, which is more sensitive for touch and for stimulation during the sexual intercourse. 87% of patients reported enhanced sexual arousal, and it may be combined by 1 LPRP, because the hyaluronic acid will amplify the area and the PRP will enhance the collagen stimulation in the area. 87%, and from my experience, it's more than 90% reported good sexual response. Regarding C-left, C-left is also injection of hyaluronic acid in the subclitoral area. It depends also on patient selection. Not all patients will have the same response if you do the C-lift or the R-short, because C-lift depends on the clitoral size or the clitoral if it's covered by hood or not. So if the patient have covered or the hood of the clitoris is bigger than the hood, the clitoris itself, she will have the benefit from the C-lift, because hyaluronic acid, even if it's not cross-linked, it will expose the clitoris outside the hood, and it will be more affected by the stimulation of sex during sexual intercourse. It will be also accompanied by any growth factor, mediated growth factors, or PrEP, which can have collagen stimulated. Even in our show, the same issue. The response of 87% depends on the patient selection. Not all patients will have the same response, because you will have the history to see what is the cause of decreased her sexual arousal response. How to deal with complications when it will happen? Injection site reaction, swelling and bruising, redness. We will just apply ice pack and firm pressure, and we will tell the patient to have ice pack in the house for the first 24 hours. Infection, the better way to deal with infection is to avoid it. But in case we have the small nodules, will be treated by antibiotics active against the skin bacteria like augmentin or azithromycin. Low-grade infection of bacteria or the biofilm, which can happen as a late complication after 4 to 6 weeks sometimes. It will also be treated by antibiotic, and sometimes it will not be effective antibiotic alone, and we need to have hyaluronidase to dissolve the filler completely. The inappropriate technique, adverse event like the implants, the bulk of the implants or small nodules, it could also can be first step to be treated by massaging and antibiotic. Later, if there is no response, we will go to aspiration or the incision by hyaluronidase injection. Usually, every 5 units of hyaluronidase will dissolve 0.1 ml of 20 ml filler hyaluronic acid. So if you need, it depends on the amount you want to solve, you will inject hyaluronidase. Allergy and hypersensitivity, which are the early allergy will be treated by antihistamine. The late allergy, like granuloma, can be developed 1, sometimes 2 years. I have cases after 1 year she had the granuloma, and can be treated by the corticosteroid injection. And usually the dose will be 5 to 10 milligram per cc and repeated if necessary 4 to 6 weeks. Usually I will use hyaluronidase before going to corticosteroid. Thank you.
Okay, so now after all the information, I'm sure there are some questions from our public, our doctors.
Give me one.
Thank you very much for organizing such an amazing scientific and well-organized presentation as well. Actually, I was expecting a question from the dermatologist. Maybe I could relate this to Dr. Carmelo. How about subcision? Could they combine the filler, whether it's MLF1 or MLF2, in terms of the bilateral hip dips, and talk about bilateral hip dips? Could they combine it with subcision?
Okay, yes and no. Why? Because when we have deformity after liposuction, for example, or after lipofilling, or just because of the fibrotic cellulitis, if we do the subcision with the needle of the subcision, the same that the dermatologist used for the face, the patient will bleed. So we are running blood on the area. So we put the filler, we fill the area, apparently everything is fine, but when the blood is absorbed, also some filler is absorbed, so the retention is still there. I do, most of the time, I use the Toledo cannula, which is a cannula for the subcision, but I inject on the same time I'm cutting the fibrotic tissue. So in this way, I reduce a lot the blood flow, the blood spilling, and it takes the result, the result stays longer. Most of the time, I need more than one session, I'm honest.
Would you do it in 2 separate sessions, or would you do it in a subsession and they come back after 48 hours after the blood has settled and then go in for the injections?
No, if I don't use the cannula, I suggest to do the injection immediately of the filler in order to fill the gap. The problem is that after 2 weeks there is a big absorption of the filler itself. When we use the fat, it's easier because you overcorrect and you know the later absorption, but with the filler you gotta be careful. So, subcision and injection immediately after, yes, I agree, it's gonna work. Sometimes, due to the inflammation process, you need more than one session to fill completely the gap.
Any more questions? I'm asking on behalf of dermatologists, because I don't do subsessions.
You stole my question anyway, as a dermatologist. Thank you for a beautiful presentation from plastic surgeons and an obstetrician. A question for you. You have a lot of posts, let's say, tummy tuck, people who reduce their weight for a big amount of weight, like bypass or something like that. During a 360 and during a butt lifting, I think we talked about this before. Can you do a butt lifting during the operation and inject the filler at the same time? I'm a dermatologist. I'm willing to hear anything.
This was a question they asked me in Hyacorp when I did a presentation. I'm honest, I never did the filler immediately after the butt lifting. Why? Because my technique, which I believe is the same on the other surgeon they use, I use a local island flap, so a dermoadipose flap. So I'm giving the volume to the buttock itself during the lifting. I don't cut everything. I do just remove the skin during the depitalization and keeping the auto implants. But yes, I use the filler after. Usually 1 month or month and a half after, when of course the shape cannot be perfect immediately, the filler will help a lot. And in this case, I prefer much more to use the filler instead of the fat. Because with the filler I can control the final result, while with the fat in the operating theater, unless you have the bed and put the patient in a straight position, it's not always possible to give the round shape.
For the question Ayman asked you about subcision or anybody with scars, as a dermatologist, usually, even if I'm planning to put filler, I use the subcision first, leave the patient minimum for 2 weeks, then ask him to come. Because I always have an inflammation, double the size if you do it at the same time. And always the patient is inpatient. So if you do both, they will not wait for the result and they say they will come after 24 hours, 48 hours and complain. So give them time, don't do immediate, don't make your, don't look for 100% in the first 48 hours. Do the initial thing of the fibrous tissue, the subcision, and then put the filler on.
Can I ask you something? Sure. You do the subcision with the needle, but you don't inject at the same time, correct?
Yes.
Try to use the tornado cannula.
I do the cannula, I don't do any.
You can inject at the same time, okay. Because I have a nice result when I inject at the same time, expanding the skin. I have to massage it, but I agree with you, there is an inflammation. The inflammation leads to filler absorption. This is something we cannot change.
Yeah. Thank you.
Questions to Anessa? Thank you very much for amazing details. Would you consider mixing the lidocaine for the first 2 nodes, like what Dr. Carmelo mentioned?
Yes, the same technique. Actually, we're following the same technique.
Maybe I missed it in the presentation.
I didn't put the.
Okay, that's why I'm asking on their behalf.
But actually, for 2 ml, we do at the entry point, and also sometimes we will inject it inside the whole labia. It will be less painful.
Yeah, before the injection.
Yes.
Yeah, so I just wanted to
Before
highlight
the injection.
this technique because it's not mentioned in the company, it's not mentioned in the presentations. The genital area is a little bit different, so I have to inject the little bit of local in the beginning, at the entry point, and sometimes we inject along the whole labia, before the actual injection of the Hyacorp, because otherwise some patients they will just freak out. There was a question. Mike, please. Please wait. Mike.
What's the number of cannula used for labia majora?
Actually, I'm using both sides, 70 or 1.
Good evening. Thank you very much. My name is Hazard Nadeem. I'm a gynecologist at the Gynecology. This is maybe a problem that I'm facing a lot with labia augmentation. Is the formation of nodules or granulomas or patients feeling some kind of swollen masses that is staying there for a long time. Might not be specifically with Hyacorp, but Hyacorp is one of the fillers that have been found to cause such problems. So number one, what would be the kind of general question? What would be the percentage if we are going to consult a patient about forming such problems, like nodules or granulomas after injection? Of course, we don't inject that much in the labia as compared to the buttocks, but again, still we see those nodules or masses. And then the second one, is there anything in the technique can avoid forming such changes or masses? And number three, what would be the best kind of, let's call it, advice to the patient if she is bothered by it without the pain, or because they may not feel pain rather than they are just feeling some kind of nodule all the time, and they keep feeling this is something maybe moving up and down. So what would be the best advice, or shall we do something to get rid of it? Sorry for the long question.
Your question is about the labia majora, the cosmetic gynecology.
In general, I mean, this is a general question about all granulomas or nodules formation.
حاضر الانسر للدكتور طبعا كذا هي كبيره هذا الشيء، بس على خصوص السؤال بالعربي او اللي كانت تقولي بالعربي. طيب بس تقول السؤال بالعربي اول بعدين
دكتور حازم يسأل عن قد ايه نسبة حدوث الجرانيولوما بالليبيا ماجورا باعتبار انه موضوعنا عم يقابل الموضوع سواء كان مع الهايكورب او مع غيره. Actually, I don't know if you have any about percentage of granuloma when you will tell the patient in the consent that he will face to have granuloma after 6 weeks in percentage of what?
I don't have a percentage. We don't have study of that amount, to be honest. I have received sometimes call from other doctors that they have this problem. And I believe, and that's why I asked, the key point is the massage. And what to avoid, don't do bolus. Because the granuloma can be caused by the bolus injection. So it can happen if you do a small bolus injection, but just massage and distribute the fluid. Which is annoying and awkward, mostly when I'm a man who recommend doing the massage and the labia majora on the woman, but still the assistant, the nurse can do it.
Actually, I don't have idea if you have percentage how much you will have granuloma after the labia and filler. But I think the technique is the most important parameter which can tell us granuloma will happen or not. And as Dr. Carmelo said, firstly the massaging every 2 ml, not every 5, every 2 ml. Secondly, not to inject a lot of filler in the area. So in Arabic, ما في نسبة معروفة قديش حيتشكل جرانيولوما بعد الفيلر بعد حقن الفيلر بالمنطقة النسائية. ما عندنا معلومات قد ايه هي النسبة حتى تقدري تخبري مريضتك عنها، لكن أكيد أنت بتخبري المريضة بالكونسنت إنه ممكن يتشكل هذا الجرانيولوما خلال 4 إلى 6 أسابيع. البارامتر الأساسي اللي بيلعب دور في تخفيف الجرانيولوما وما بالضرورة يضمن إنه ما يتشكل هو المساج الصحيح، لأنه نحن كميات قليلة ما يتم حقن فوق ال 15 ml بهي المنطقة. اختيار المريض الصحيح طبعا هذا أحد الأشياء، يعني ممكن ست تجي عاملة فيلر بمحل ثاني وعاملة جرانيولوما وبدها تجي تعيد عندك الفيلر وهي لسه في عندك جرانيولوما، فهذا يعني الدكتور كارميلا دكتور أيمن do you repeat filler after previous granuloma in the labia majora or in any area in the body before you dissolve the previous granuloma?
Absolutely لا، ما أحمل في منطقة أساسا فيها مشكلة ضغط أو جرانيولوما. طبعا
اختيار المريض اختيار المريض المساج، التكنيك، الكميه، هدول البارامترز اللي ممكن يحددوا هل ممكن يصير في جرانيولوما او لا، بس برسنتج واضحه عن قديش نسبه تشكل الجرانيولوما.
في حاجه مره مهمه ما تكلمنا عنها، الابر هذه they're actually implants. they're not just filler. لازم نتعامل معهم على انهم هم implants. بتكلم هذا النقطه من ناحيه الانفكشن، من ناحيه الاسترلايزيشن، والحمد لله التهاباتهم جدا نادره، ولكن احد مشاكل الجرانيولوما هو البايوفيلم. So sterility, sterile technique can increase the number، ممكن يقلل احتمالات الجرانيولوما. لذلك لازم نفرق ما بين اللمب والجرانيولوما. اللمب هي المريض يخرج فيها من العياده ساعتها، وهذه المشكله تكون معناها ما تسوى لها مساج كافي في العياده. اذا المريضه خرجت بلمب من العياده في تلك اللحظه ولسه عندها لمب او كلمتهم من البيت قالت عندي لمب، هذه معناها ما تعمل مساج كافي في العياده. اذا المريضه صار ظهر عندها لمب بعد اسبوعين بعد شهر، هذه الجرانيولوما، واحد مشاكلها ممكن تكون انه كان في كونتامينيشن اثناء البروسيجر، وصار عندها بايوفيلم، وصار عندها كبسوله بعد. هذه الدفرة both ways، كان هذه ولا هذه، المفروض ما نحكم زياده على هذا الشيء الا بعد ما نحل المشكله الاولى، عشان ما تكون المشكله متراكمه، خاصه لو كانت المشكله الاساسيه فعلا هي contamination وبايوفيلم، ممكن تسوي انفكشن.
Actually, it's not a question, it is an advice for all my colleagues. Take an extra 5 minutes or 5 دقائق زيادة with your patient and take a good history. Ask the question 3 times to your patient. اسأل مطلع. سويت شيء عن أحد قبل كده. Did you do a procedure with somebody? Did you receive a problem? Did you have a lump? Did you have a fibrous tissue? Take an extra time so you will not face a problem. مشكلتنا لما يجي مرضانا يخش المريض عايزين نخلصه في 3 دقائق. When the patient comes, we want to finish him in 3 minutes to decide to inject. No, take an extra 4 minutes, take a history, you will not face a problem. It's just an advice for all.
And actually, Dr. Hassan, this is a foreign body, and the response of any patient is different when we would inject a foreign body. من خبرتي او اكيد انت شفت ممكن تحقن الفيلر لست تيجي بعد شهر تقول لك انه راح، في ست تيجي بعد سنه تضل موجود، في ست بعد سنه تكون ساتيسفايد، بعد سنه تيجي تلاقي في لمبه صغيره بعد ما هو ديزولف. يعني عم نشوف ريسبونس مختلفه بين البيشنتس لانه هو فورين بودي بالاخر، وكل ست لها يعني كل جسم عنده ما هي في ريسبونس واحده. يعني في ست بعد اسبوع تيجي تقول انا ما عندي شيء، انا مكاني ما حقنت زيدي. ففي ست لا بضل موجود معها، وفي ست يعني الريسبونس على فورين بودي بين جسم وجسم بيختلف.
Any more questions from the audience? Please, comments, advices?
Expectations of patients.
Good.
Expectation of patients.
Yeah. Make sure that you discuss the expectations. توقعات المريض عقلانية أو غير عقلانية قبل ما تدخلوا أي شيء، قبل ما تتواصلوا مع المريض، المريض توقعاته خيالية وهذه الأشياء ما يمكن توصل لها في الفيلرز فقط. أوكي. أي أسئلة؟ توقعات، comments، مجاملات، انتقادات، criticism. Okay, I leave the floor now for Patricia.
Everyone who joined us tonight, to our doctors who have delivered an excellent evening and contributed their valuable input. Let's enjoy a delicious dinner now, and I hope